Welcome to today's webinar, Cardiovascular Disease and HIV. We would like to introduce Dr. Turner Overton, MD, Professor of Medicine at the University of Alabama at Birmingham in Birmingham, Alabama. Welcome, Dr. Overton.
Thanks, Jose, and good afternoon or morning, depending on where you're located, everyone. So as Jose mentioned, I'm Turner Overton, coming from the gloomy Birmingham, Alabama this morning. I'm on the first slide here, and please note that there is the ability to pull this up on a webinar, and you should have access to that. There will also be some opportunities for questions during the talk, so stay engaged, and we'll see if we can answer any questions there are. Here's just a good-looking picture of me there, and one thing that we request is, if you will, please enter your full name in the chat box with your institution, and that way, we'll be able to quantify and qualify the people who are on the call, but also that's your mechanism to get CME or other credits, and that's the way to verify your participation. So please do that. These slides and all IAS-USA slides are available on the website. They have a new website, which is listed there. And then they have a frequently asked questions that you can go to as well. All you need to get access to that site, and there are lots of good slides, cases, etc., is your email address and your password, and it's easy to reset. As I mentioned, there are CME credits available, so it's 1.5 CME credits for physicians, and then the next slide as well, there's nursing and pharmacy credits as well. So, hopefully everybody can get a few nuggets for the bean counters for today's call. I do want to thank, I want to first thank all the staff of IAS-USA of helping put this together, and then the funders of IAS-USA as well. And you can see them listed on this slide. They provide funding, and then all the content is provided by speakers like myself and reviewed by other scientists, researchers, etc., who vet all of the materials. We're going to do some poll questions, so I hope people are staying awake. We'll be able to tell. So we're going to start with some easy poll questions, and there will be a couple during the talk as well. So you're going to see a box pop up in just a second, and you will choose your response from the poll itself and not from the chat box. And then after the poll closes, we'll show the responses. If you have a question during the talk anytime, please feel free to type it in, and we will we'll answer it, or we'll try to answer it. And like I said, we have some breaks. I've broken the talk down into 3 sections, so hopefully it'll be somewhat interactive at least. All right, so here we have our first poll question. Please tell us from where you hail. The unfortunate thing is I don't have any music to regale you guys with. That's the best part of these. I will tell you that people are responding. It's still ongoing, so I'm going to wait until we have pretty good response. Okay, and we're broadcasting results. Can we broadcast results? Jose, do I need to hit the next button? I'm going to hit the next button. All right. So I don't know if people were able to see those or not. The next poll we have is for asking people to rate their level of experience in the management of HIV infection, from 1 being novice to 5 being expert? I was under the assumption that these would be, we'd be able to show these, but I'm not sure if we can show them or not. Okay, so we will be able to see them. I just don't know when we're seeing them. They should be seen right now, and so if people can see those, I will just tell you in terms of the experience. We have a pretty experienced group, with the majority of people being 3, 4, or 5. So that's good. I mean, I think that we have people who are going to be experienced and know about HIV, and hopefully talk about some of the things that we don't always talk about. We don't always think about in clinic. We focus on HIV and HIV management, but there are many things, obviously, that are happening in our clinics and to our patients, and we need to make sure we're kind of addressing them holistically. All right, so let's see if we can get back to the talk. Okay, there's this slide again. That's exciting. Okay, and here are my sins, as they say. I've served as a consultant or advisor for Merck Technologies and ViiV Healthcare. So in our learning objectives, and this kind of is along with the 3 focus areas we're going to have. First, we'll talk about the changing epidemiology of cardiovascular disease. We're going to talk about risk factors, and hopefully you'll be able to identify risk factors for cardiovascular disease. And then finally, really develop some patient-centered strategies to prevent and manage cardiovascular disease, and really focusing more on the prevention component than on the management. I think once people actually have an event, we often get them involved with the cardiologist, and our goal really is, let's see what we can do to prevent comorbidity. And so I've got 2 pretest questions. We'll do these before and after. So this first question is, which of the following best describes the incidence of cardiovascular disease in people with HIV over the last decade? Is it decreasing? Is it increasing? Is it stable? Is there no data to inform the epidemiology of cardiovascular disease in people with HIV? Okay, seems like we have pretty good consensus that it's increasing, so that's good. People are familiar with kind of the epidemic. We have a second question for you. So which of the following statements about cardiovascular disease in people with HIV infection is true? Number 1, HIV infection has no effect on cardiovascular disease risk in people with HIV. People with HIV experience limited efficacy from lipid-lowering therapy. The primary rationale for initiating lipid-lowering therapy is to prevent cardiovascular disease. Or 4, diabetes does not increase the risk of cardiovascular disease in people with HIV. Give people just a minute to respond. All right. So maybe I just did questions that were too easy. I'm probably a bad, everybody in my class at the School of Public Health makes an A or a B. Maybe that tells me something. I need to make my test harder. All right, but nevertheless, I think that the majority of you recognize that the primary rationale for lipid-lowering therapy is actually to prevent cardiovascular disease and not to lower lipids. And so we'll talk about that a little bit. I think sometimes we find ourselves chasing a value, and it's probably more important to be thinking about what we're trying to prevent. All right, and we'll come back and talk about that. We'll talk about all of those. Okay, so like I said, I'm going to break down the talk into 3 different sections, and the first section is sort of the epidemiology. So what's the buzz? What are the clinical issues facing our patients? What is the issue? What's the deal, man? So I thought I'd start and just kind of contextualize this. We're talking about cardiovascular disease, and why do we consider cardiovascular disease and HIV in any standpoint at all? And I think one of the big recognitions in the last decade or so has been the recognition that the formation of atherosclerotic plaques, atherosclerosis, is an inflammatory, progressive process. And so it's not like people just wake up one day and they have a big plaque that forms and ruptures. There's an ongoing process. And so it really develops as a focal thickening on the inner layers of the artery. And you can see those. Let me get my pointer. If you look right here, so you often hear people talk about the IMT, the intima media thickness. So this part of the vessel and the artery is often what we're talking about when we do some of those testing. Normally this part of the vessel is very thin. When you have any kind of disease process or inflammation along this surface, you end up recruiting different lipid particles and proteins into the intimal space, and then these attract these monocytes, and these monocytes come in to gobble up these proteins and these oxidized lipid proteins, lipid particles, LDL, oxidized LDL, to form foam cells. This thickens, and you get what's called a lipid-rich plaque that is very prone to rupture. So it's an ongoing process that goes from a normal thin layer to it gets to this enriched foam cell plaque that is prone to rupture. And so this is an ongoing process with what's happening here on the vascular level with inflammation or irritation. And furthermore, people that have excess inflammation can contribute two ways: by having the particles that can get laid down in here, and then by being enriched with these inflammatory monocytes that can come in. And so what you have is you get some arterial wall injury, the deposition of these lipoproteins, activation of the endothelial cells, pro-inflammatory molecules that recruit these monocytes to form foam cells and advancing atheroma. So we'll come back to that concept, but I think the concept is a good one to think about this as an ongoing inflammatory process. So as I put that in for you, I always like to share a little data about who I am and what I do. So I'm a clinical researcher, but I also am the medical director of a large Ryan White clinic in Birmingham, Alabama. And so like many of your clinics, we have an expanding population. Over the last 6 years, we've had near doubling of our patient population. One reason we're doing a better job of keeping our patients alive and doing well with the advances of antiretroviral therapy. Furthermore, we're having more people identified and coming to clinic. And so what we see is we've gone this doubling over time, and really excellent work. And I think when we talk to people around the country, excellent work in terms of virologic suppression. So 96% of our patients are currently receiving antiretroviral therapy, 93% are below 1,000, and 83% are below the level of detection in terms of HIV therapy. So this is really outstanding. Another way we can look at this is saying when people are coming to our clinics, what are their CD4 counts? So as recently as 2007, a large proportion of our patients, just under half of our patients, were coming in with an AIDS diagnosis and a CD4 count below 200. And what you can see over this decade, we've had a marked increase. In fact, the data from 2018, which I need to update this with, our entry CD4 counts are just below 400 on our clinic. So we're seeing many fewer, AIDS-defining illnesses with this, which is wonderful. But we have patients that have many comorbidities that we need to make sure we're addressing. And so I could have shown the data from our clinic, but I really like this data that comes from Europe. And one of the reasons I really like this data is because they have a matched HIV negative cohort they can compare to. So basically, this is the age HIV cohort study. And what you can see over here on the left are just the comorbidity prevalence. And when you look across, you can see this dark bar. It's higher for all of these comorbidities than the lighter gray bar. And while not all of these reach statistical significance, you can see when they compare the HIV negative in the light gray to the HIV positive in the dark gray, an increase in the HIV positive. And some of these reach statistical significance: hypertension, myocardial infarction, peripheral artery disease, impaired renal function. These are some of the comorbidities I think all of us are familiar with. On top of that, in a second analysis, when they looked at multimorbidity, which I think is a concept many of us are becoming familiar with, multimorbidity, the presence of two or more comorbidities among an individual, was much more common among the HIV than in the HIV uninfected group. And so if we come over here and look, and if we take specifically the group of, say, 60 to 64 here, you can see multimorbidity when people had two or more was about 50% of the HIV patients, but only about 30% of the people living without HIV. So you see a marked increase in terms of multimorbidity with our patients with HIV. And so I think many people have this concept, and I think there's still debate, but I do think that HIV appears to accelerate the prevalence of multimorbidity, and including cardiovascular disease. I always like to show Virginia Treon's data from Boston. I think this is really informative. This is one of the early studies that really highlighted this difference in terms of acute myocardial infarction among people living with HIV. And so basically they took all of the hospital admissions in two Harvard hospitals, and which included just under 4,000 people living with HIV and 1 million HIV negative adults. And they looked at acute myocardial infarction rates. And what you can see is there were about 12 MIs per 1,000 patient years in the people with HIV, and only about 7 in the HIV negative, giving a striking relative risk of 1.75. And secondarily, what Dr. Treon did is she broke this down by age groups, and even at the earliest, the relatively young adult, you see this disparity between HIV and HIV negative. And the HIV negative does increase with age, but there's a disproportionate increase in the people living with HIV. So now, some of this may be related to it was relatively early in the epidemic, and there are lots of confounders with the early ART, but nevertheless, we see an increase which is disproportionate and not explained just by age and risk factors. And there are many, many studies now that have looked at this, and consistently what we see is a 1.5 to a 2-fold increased risk of cardiovascular disease, and that's really comparable to traditional risk factors such as hypertension, diabetes, hyperlipidemia, or smoking. And this puts people at risk not just for myocardial infarction, but for stroke, heart failure, pulmonary hypertension, and venous thrombosis. There's really a lot of growing literature that supports this notion that HIV is really a big driver of heart failure and pulmonary hypertension, and those are areas under very intense research right now. Priscilla Hsu, who's a cardiologist at UCSF, recently wrote a letter to the editor highlighting the risk that HIV contributes, and just really confirming what we thought. First, what they did is they reported on the Inter-Heart study, which looked at HIV-negative individuals. And you can see these common risk factors: hypertension, diabetes, lipids, smoking, all convey a 2.5 to a nearly 4-fold increased risk odds ratio of cardiovascular disease. In a study by Shaw, you see a little over a 2-fold relative risk. Now, you may say, well, those don't look equal, but just realize relative risk underestimates the actual risk, whereas odds ratios tend to overestimate. So these are very similar risks, and so once again, you get this sense that HIV is contributing similarly to other comorbidities that we commonly think of causing cardiovascular disease. Matt Feinstein recently published in the American Journal of Cardiology about the changing burden of cardiovascular disease among adult people living with HIV, and here he broke it down by men and female and by different races and ethnicities, I think you can get a sense that from 1999 to 2013 for both men and for women, we're seeing a 2 to 3-fold increase incidence of myocardial infarction and other, this is actually mortality related to cardiovascular disease, but just a striking increase over time. And, this is coming at the same time where we're seeing a decline in cardiovascular disease mortality in the general population. And this is really a nice study. If people are interested in the epidemiologists, go read this study. And I think it, once again, takes us back. I do want to get back to this sense of behind the scenes what is happening. And I think that we all assume, aging is happening to all of us regardless of what we do, right? Your birth date can't change. I haven't been able to change it yet. But that doesn't necessarily, our chronological age does not necessarily equal our biological age. And there are many key factors that can contribute to this accelerated aging phenotype. Now, obviously, just the passage of time itself, but there are many things that may be enriched in the general population and with our patients. So having certain diseases may accelerate this process. There are many behaviors that we have and that are likely enriched in our patients. The use of tobacco, the use of illicit substances, heavy alcohol use, physical inactivity, poor diet, all of these things. And then there are things that are out of our control, such as genetic factors. And finally, one thing that we don't talk a lot about are some of the life stressors that may be affecting many of our patients, may have kind of accelerate this aging process. So that's the end of the phase 1 or section 1. And so I think that all of us know and recognize that our patients are doing well with antiretroviral therapy and living longer. So we're extending their lifespan, but they're having increased comorbidities and many challenges that this creates. And so perhaps they're having what can be considered a decreased health span. We know that specifically cardiovascular disease is increasing in prevalence, and we know that cardiovascular disease is more prevalent among people with HIV compared to the general population. So maybe I'll stop and see if anybody has any questions. It looks like there are a couple of questions. Someone asked me about the virologic suppression from our clinics. Are we looking at those prescribed medicines or all of the patients? So we do report in kind of the 90-90 format those who receive medicines and then are ultimately suppressed. You can also do the numbers and calculate from the total patient population. So she also asked me about the CD4 count, I think, does that reflect for people who are truly naive or people who are just referred from our clinic. There are two lines. There was a red line and a blue line on that slide, and the red line reflected people who were naive to therapy coming to clinic, and the blue line reflected all comers. So obviously we all get some patients who are being referred in already on therapy, and so they tend to have a higher CD4 count. And if someone wants to email me directly, I'm happy to talk to them about those data. So another question that is a good one. So if CVD is related to inflammatory effects of HIV, even when especially when unsuppressed, and if increasing percentage of people with HIV are successfully on therapy with full suppression, why has the incidence of CVD increased over the past decade as implied by your opening question? So we'll come back and talk about that a little bit over the next two sections. I think that's a really good question. And there's a question about what risk results from well-controlled diabetes and hypertension. So I do think, when we do a better job of controlling someone's diabetes or hypertension, you actually reduce their risk. You're not going to completely attenuate that risk, but you can markedly reduce their risk of the consequences of both of those diseases. And so here's a question. When along the process of HIV does it start affecting cardiovascular disease? So I think that's a really interesting question. I have one slide coming up from the START study, the INSIGHT START study. I think there is a presumption that as soon as you have a chronic viral infection that it increases inflammation and starts to drive this pro-inflammatory milieu in the body. But there actually may be some data that suggests identifying people very early and getting them on HIV therapy may limit how much chronic inflammation you have. And I think that's an area that's under a lot of intense scrutiny right now. But we will talk about that a little bit. Okay, so people must still be awake because we got some good questions, and thank you guys for those. If you do have more questions, please type them in the chat box, and we'll talk about them again. So the second thing, so hopefully you agree with me that despite antiretroviral therapy, we're seeing more cardiovascular disease among our patients. And so we know the what, cardiovascular disease, and so the next question is the why. So really, to address the problem, we need to know what the root causes are and why are our patients experiencing these higher rates of cardiovascular disease. So I think one problem with any system like the human body is it's complicated. And with it being complicated, it means there are lots of different factors that are contributing. Peter Hunt often likes to use an example here of a whack-a-mole. So if you address one problem, it just pops up somewhere else. And I think that's not inaccurate. I think it is sort of challenging when you have a multifactorial problem. You have to be multifactorial in your solutions. And really it is an interplay between the traditional risk factors that we know a lot about from the general population. There are many HIV-specific risk factors that are related to the immune derangements associated with HIV. There may be specific HIV medication-related toxicity. And as I mentioned already, there are certain behaviors that may be contributing to the increased risk. And then finally, many of our patients face health disparities, and so that may also be contributing. One whole area that I don't really touch on in this talk is the relationship of mental health, depression, etc., on cardiovascular disease and end-organ disease in general. And I think there is a growing literature recognizing that depression and mood disorders can have a big impact on many of these comorbidities. Another way we can think about this is breaking this down here in this Venn diagram. I mean, there are host factors, so things that some of this is out of our control, our family history, our genes, but some of these things are things we choose to do, smoking, alcohol, excuse me, sedentary lifestyle, are all things that we make choices about that may affect our risk. There are obviously HIV-specific effects, and we'll talk about these a little bit more, not just the effects on the immune system, but also effects on coagulation and lipid profile, which may increase our risk. And then there's antiretroviral toxicity. So once again, there may be effects of antiretroviral therapy. Obviously, there are benefits, and those clearly outweigh a lot of the risk. But one of the big reasons why we've advanced antiretroviral therapy is to reduce the toxicity of the early therapies. And I think there's good data that supports not just cardiovascular disease, but a number of what we consider aging-related comorbidities are also seen more frequently, or at least in earlier age, among people living with HIV. And one common pathway that's driving this with both aging and HIV is an increase in systemic inflammation. So maybe we'll call it inflammaging. And I'd like to just take a step back and think about what is the immune system doing and how it is, how the alterations related to HIV may be contributing to end-organ disease and cardiovascular disease. And so for a long-lived organism like a human, it's really critical that we have adaptive immunity. So when we confront the same pathogen, we don't have to go through, a severe illness or creating a robust immune response to that pathogen. On the second time that we see it, we've developed an adaptive immune response, which is really what our T cells do. And so when you think about it, when we are faced with a new pathogen, and particularly intracellular infections and viruses like HIV, we have a rapid expansion of killer T cells or effector T cells, which are CD8 cells. They're short-lived but highly functioning, and they target the infected cells and kill them to clear the pathogen. At the end of this process, we also develop a pool of memory precursor cells, CD4 cells, that will recognize this pathogen in the future, and along with memory CD8 cells, be able to respond rapidly when we are reconfronted with this pathogen. And that gives us lifelong immunity. And this is an unbelievable tool in our arsenal. And it is, we have T cells that can expand 50,000-fold during an infection, and doubling in 8 hours, and the power to kill target cells within 5 minutes of engagement. And that's really a remarkable response. So the second time we are faced with a pathogen, we can clear it almost immediately. And that's why people, often have a lot of illness as children, and then less so as they age. However, when you're confronted with viruses that are able to evade our immune system, the initial immune response, this can be challenging. And because these viruses then can lead to low-grade activation of the immune system and ultimately exhaustion. And there are really two types of viral infections that cause persistence. The first are viruses that are latent, truly latent. So they're not producing proteins or new virus except intermittently. And so these are some of the herpes viruses like herpes simplex virus 1 and 2 or varicella virus. So often their genomes could be integrated or exist as episomes, and they reactivate intermittently. Maybe there's a stressor or as people get older. So some of these are the viruses we see in our cancer patients or bone marrow transplant patients. And these don't tend to cause the same amount of immune activation and exhaustion that we see with the truly persistent virus that are ongoing, replicating in an ongoing fashion, some of which at a low level. And we can think of HIV as being the biggest example of this, but also hepatitis B or hepatitis C, CMV, and EBV are similar viruses. And what these do is they cause this ongoing process of T cell activation and then exhaustion. And it has two effects. Number one, it can increase systemic inflammation and thereby cause end-organ disease. It can also fail to generate adaptive immune responses to clear other pathogens in the future. Alan Zajac, who's a microbiologist with whom I work, who studies a lot of chronic viral infections, has kind of created this model of persistent viral infections inducing this exhausted state among both CD4 and CD8 cells. And CD8 cells are a little bit easier to show because when you have a functional CD8 cell that's confronted with a new pathogen, it's a very functional cell. And it produces many antiviral proteins, induces cytotoxicity, has a low level of inhibitory receptor like PD-1 presentation. They can proliferate to form more cells, and so really active cells. But as you have chronic viral exposure, these cells become exhausted, and you see a loss of their effector functions, and you see an expansion of the inhibitory receptors, and you see more apoptosis. So a loss of their function, upregulation of these inhibitory receptors, loss of self-renewal capacity, and compromised viral control, and then really this enhancement of pro-inflammatory cytokine expression, which may be particularly bad for end-organ disease. And so it leads us to this kind of inflammation hypothesis, and this actually comes out of the cardiology literature, where they recognize, once again, you have inflammation as inducing this end-organ disease. So regardless of what the stimulus is, whether it's a chronic infection or a toxin or some abnormal protein, this drives a process that's supposed to signal our immune system, these mediators. And in the ideal world, our adaptive immune system is able to respond and terminate this response, terminate the stimulus, and healing ensues. However, when you have ongoing persistent exposure to this, say like beta amyloid or the tau protein in Alzheimer's disease, you get progressive fibrosis and cell death, and it can lead to any one of these diseases. And so if we think about HIV as being that chronic stimulus, You have chronic HIV with viremia, viral proteins, and this can progressively lead to end-organ disease, and not just heart disease, but kidney disease, cognitive impairment, liver disease, and frailty, and all of these at a premature age. We know that a key driver to many of these non-AIDS events is inflammation. This is a study from the NIH-funded AIDS Clinical Trials Group, where we looked at a longitudinal cohort study and identified people who developed these non-AIDS events, cardiovascular disease, strokes, and others similarly. And what was found with this was in the people who developed these end-organ disease manifestations, non-AIDS events, increased measures of systemic inflammation, even after adjusting for many comorbidities, for many other factors. Similarly, in a veterans aging cohort study where they looked at all-cause mortality and the relationship of inflammation, what they found was really, really interesting. I find this study to be really informative because it really heightens that the inflammatory component of HIV is what is really a key factor of this. Now, mortality rates were higher among HIV-infected individuals. And then what they did is they took the HIV and the HIV-negative group and they split them based on if they had high inflammatory markers or low inflammatory markers, and then looked at their mortality risk. And the interesting thing is, here in this image, or this figure, I'm looking at soluble CD14, which is a marker of monocyte activation. But there are other markers they looked at as well that show similar data. And I think what you can see, and what's really intriguing, is that here in the yellow you have HIV patients, people living with HIV with the highest level of the inflammatory biomarkers do have higher rates of mortality than HIV-negative individuals with the high rates of the inflammatory biomarkers. But the people, HIV-negative individuals with high inflammatory biomarkers actually had higher mortality than the HIV-negative with than the HIV-positive with low inflammatory biomarkers, really suggesting that it's not just the HIV, but the inflammatory and immune activation consequences of HIV that are driving that. And so if you have inflammation from any cause, whether that be from HIV or something else, chronic smoking, underlying lung disease, etc., you may, that will increase your risk. So yes, HIV infection was in general associated with higher levels of these inflammatory biomarkers. And these biomarkers predicted mortality, but they predicted it not only for the people living with HIV, but also for the people living without HIV. And so one of the reasons that, obviously it's really important for our patients that we study these issues, but what we learn from our patients with HIV may have implications for the general population as well. And so that brings me back. So I talked about this earlier, and this notion that atherosclerosis is an inflammatory process. I haven't talked much about the monocyte pool of cells, but you hear a lot of talk about monocytes, which are part of the innate immune system and kind of early responders. And so once again, when we get deposition of these oxidized proteins, LDL cholesterol proteins, into the intimate space, this attracts circulating monocytes to come to migrate. They adhere to the wall of the endothelium here, and they migrate across, and they form these foam cells. In the ideal situation, after they gobble up all this oxidized LDL, they will kind of pass through, and they either will reverse transmigrate and then go back to the liver, or they'll pass through drain to a lymph node and clear. And so you just have a regressing plaque. But in a situation where you have heightened inflammation, so for instance, say this endothelium is injured and expresses more of these adhesion molecules, or you have more circulating inflammatory monocytes, or you have more oxidized LDL depositing, all of these factors may lead to a greater buildup of these monocytes forming these foam cells, and you have a progressing plaque with more foam cells And you see this lipid-filled plaque that is prone to rupture. And so why would that story be important for HIV? Here's data from Nick Funderburg, where he basically looked at HIV-negative individuals and then two groups of people living with HIV, suppressed on HIV therapy or unsuppressed. And what you can see is in the general population, you have a higher amount of normal kind of what we call patrolling monocytes. But as you, with HIV, and particularly with untreated HIV, you have many more of these nonspecific monocytes and then these inflammatory monocytes. And so these very inflammatory monocytes are the ones that are more likely to be patrolling and get sucked into that intima and form foam cells and build the plaques that can rupture. And so the monocyte population, similar to the T-cell populations in HIV, are altered. You have decreased classical monocytes and more of the inflammatory and patrolling monocytes that go to tissues. And while antiretroviral therapy and virologic control may shift the monocyte population back towards normal, they remain altered. They don't return absolutely to normal. Now, I also mentioned these cholesterol particles as well. And the one and obviously I think everyone knows about HDL cholesterol being your good cholesterol and LDL being your bad cholesterol. Well, particularly not just LDL, but LDL particles that get oxidized, because these are the ones that get deposited into your intima and then serve as the basis to recruit monocytes to become foam cells. And what you can see is in the HIV, where did it go? There it is. In HIV, once again, higher levels of oxidized HDL than in the HIV uninfected. And similar, I mentioned earlier soluble CD14, which is a marker of monocyte activation, higher in the HIV group than the HIV negative group. Monocytes that patrol specifically to the vasculature often express soluble CD163, once again significantly higher in the HIV than in the HIV negative. And these oxidized LDL particles correlate with monocyte activation and correlate with these inflammatory monocytes that are going to target the intima. So we have this situation where you have excess oxidized LDL, you have these excess inflammatory monocytes, and these two things correlate with one another. Now, somebody asked me earlier about both controlled and uncontrolled HIV, and I think we know that uncontrolled HIV replication is bad. It's a simple statement. And in terms of from a cardiovascular standpoint, this slide, this is a nice review paper that Jason Baker put out nearly a decade ago. But I think what we recognize is, number one, HIV causes just general inflammation. This inflammation can be measured by different biomarkers. IL-6 and high-sensitivity CRP are two we consider. It also causes excess coagulation, and you can measure that with D-dimer. And then it alters your lipoproteins, and you get more of these, less HDL cholesterol and more oxidized LDL. All of these factors contribute to endothelial dysfunction, which then can promote these foam cells, cause the formation of atherosclerosis, and ultimately cardiovascular event. So obviously uncontrolled HIV does these things, and they're not completely attenuated when we treat our patients. There are a number of individuals who have looked at vascular inflammation in the setting of HIV, and these are two papers. I had the good fortune of working both with Kevin Yaroshevsky and Markella Zani to look at this very issue, and comparing HIV negative to HIV positive. What we see are in people living with HIV, there are increased metabolically active macrophages, greater non-calcified metabolically active rupture-prone plaque. And here's an image, or some images from Dr. Zani, where she looked at different ways that you can characterize with CT angiography of the vessels. And what you have here is the LAD, And what you can see first is what we call a low attenuation plaque right here. That means it's not calcified, and that means it's full of those foam cells. And you can imagine this is a plaque over the top, and this type of having a large low attenuation plaque puts you at very high risk for rupture. You can look at this longitudinally or the head-on view here as well. There are other ways that you can characterize this in the cardiology and the radiology literature based on whether the remodeling of the plaque and the calcification within the vessels. But I think that this gives you a sense of what we're talking about when we're talking about these lipid-enriched foam cell plaques that are at risk for rupture. And so how is HIV unique, and why should we be worrying about cardiovascular disease in our patients? And I hope that in this section we've kind of talked about some key things. And this, once again, is a cardiology paper that highlights, that focuses on HIV's unique features. And I won't go into everything on the slide. We've talked about many of these things. But some very unique features of HIV, number one is the change in these regulatory T-cell populations. We talked about this T-cell exhaustion and the consequences of that. I haven't talked too much about the changes in gut mucosal integrity contributing to excess microbial products that can translocate and cause systemic inflammation. But all of these things can contribute to this lymphocyte activation, senescence phenotype, activation of monocytes and driving to this more inflammatory monocyte, excess inflammation, a hypercoagulable state, and pleuroatherogenic lipid profile that even in the setting of treatment increases the risk of our patients' cardiovascular disease. So I spent a lot of time focusing on what makes HIV unique, and somebody has asked wisely, what about traditional risk factors? And so I've presented data already from NA Accord, and I want to go back and present some additional right here as we transition to the next section. So we can focus on the HIV component, and we should. Now, unfortunately, there's not a whole lot that we can do for some of these things, but we need not forget about traditional risk factors. So Carrie Alsop actually recently published, she presented this at CROI last year, talking about the contributions of both traditional and HIV risk factors for myocardial infarction. And while they don't have biomarkers in this study, and they can't go back and look at some of those issues or T-cell or monocyte activation, you can get a sense that the drivers of cardiovascular disease in NA Accord is really related to traditional risk factors. So ever smoking, 37% attributable risk of cardiovascular disease. Elevated total cholesterol, 44%. Hypertension, 42%. So we really need to remember that traditional risk factors are big contributors as well. So we can't just pat ourselves on the back and say, well, we've got this person virologically suppressed, we don't have to worry about anything else. We need to focus on being aggressive at treating these things that we can control, like blood pressure, like diabetes, like cholesterol. These are things that we can target. The interesting thing on this very slide, if you look over here at, controlled viremia, yes, it's important, but only 5% of attributable risk is due to uncontrolled viremia in this NA Accord study. So we don't want to lose sight of these important areas that we need to target. So why? So, HIV is a chronic viral infection, and as such, it induces persistent low-level inflammation. It alters our T-cell and monocyte populations. It alters the lipid profile and increases circulating oxidized LDL, and it increases vascular inflammation. So all of these things can tip the balance towards the formation of a plaque. Persistent inflammation facilitates the development of these rupture-prone plaques, but we don't want to forget that traditional risk factors are really important, and we need to address those. So before I go on to the, what can we do about it, do people have questions specific to this part or to any part of the talk? All right, everybody's now gone into a food coma. They ate lunch, they're chilling. All right, so what can we do? How can I change these outcomes? I mean, I'm a provider, I'm in clinic. What can I do? What are the relevant interventions? We don't have that many anti-inflammatory interventions. Those are being studied. Many of those studies would be good to do. Someone just asked about long-term non-progressors. Which inflammatory markers would you check? This is a really interesting question. We don't know what to do with non-progressors. They tend to have measures of systemic inflammation similar to people living with HIV who are controlled on ART. While they have virologic control, they also have higher levels of inflammation. There's even one study that suggests some of their end-organ manifestations are higher than the general population. I think that that's an area that really needs to be studied. I'm going to talk a little bit about what interventions we should be doing, and I thought I'd start it with a case that's kind of built on one of my patients. So this is just a 45-year-old white male who presents for care. He smokes. He has a BMI of 24.5, so he's normal weight. His blood pressure is moderately elevated. He doesn't exercise. His CD4 count is 325. Viral load 42,000. You can see his cholesterol panel there. So what's the most important intervention to reduce his cardiovascular disease risk? So I can see who's still paying attention because we're going to do a question and audience. So is it smoking cessation, initiate the Mediterranean diet, initiate statin, initiate aspirin, or initiate ART? All right, so people can see here. So this may be an unfair place to put this, and I think you can make the argument that I need a sixth answer, like all of the above. So I'm gonna hazard that, in my opinion, the most important thing is to initiate antiretroviral therapy. But I don't disagree that we need to be more aggressive at smoking cessation for all of our patients. Without antiretroviral therapy, we wouldn't have the opportunity to be talking about cardiovascular disease. But I agree that all of these things could be done. I don't put this as a pre-test question because I think it is sort of a challenging one. But I just want to share some data, again, as we get into what we can do for our patients from the New York Department of Health. And basically, for over a decade, from 2001 to 2012, they reported on all of the people living with HIV and from the rest of the population there to compare rates of cardiovascular disease. And they also now have looked at cancer data, and they see something similar. First thing, if you look at this figure, so just like for all of us, they've had a striking decline in HIV-related and AIDS-related causes of death, but an increase in cardiovascular and cancer-related deaths here on the bottom. And so what you can see is there's actually been a 54% increase in the mortality related to cardiovascular disease among the HIV, people living with HIV, where it's been decreasing in the general population. And this is even after adjusting for age, sex, race, ethnicity, location, and year. So this is exactly some of the data we talked about earlier. What was striking from their analysis is in the group who were consistently suppressed, they saw a halving of the risk of cardiovascular disease mortality. So mortality for people that even had one viral load that was greater than 400 had a doubling of their cardiovascular mortality. So just by suppressing people, we can have a big benefit in terms of reducing their risk. Now, however, for both groups, this risk, the rates were still higher than in the general population. And so, once again, we need to be aggressive in getting people suppressed, but then thinking about the other factors that we can treat. Now, earlier I mentioned the INSIGHT START study, where people with very high CD4 counts above 500 were randomized whether to initiate antiretroviral therapy or defer to 350. And what they saw, there was clear benefit in terms of starting antiretroviral therapy high. And it was true for both AIDS-related events or non-AIDS-related events. But what was striking when they looked at the non-AIDS-related events for cardiovascular disease, there didn't appear to be a whole lot of benefit. And so this is sort of interesting. And the question is, do you require some level of immune dysfunction before you start to see some of these end-organ disease? And you know, I don't know that I have the answer to that. There are some caveats to these data. A significant number of these people had very low viral loads when they started. Obviously, the population was relatively young. Maybe they had not had HIV long enough. A number of them, a good proportion, had only had HIV for 1 year or less. So there might be some caveats to this, and this may not be completely applicable. But I think it does speak to the fact that if we get our patients on therapy early, we may preserve some of their immune function and not see some of the immune derangements that are contributing to HIV. So I think that it's really critical that we get our patients on suppressive antiretroviral therapy. And beyond that, there are many things that we need to do. And once again, this gets back to this multifactorial situation. And one of the challenges that we have in only seeing our patients every 6 months now is it gives us less time to talk about all these prevention items, whether that be smoking, diet and lifestyle through exercise and diet, lipid-lowering therapy, or other traditional factors like hypertension or diabetes. So, you know, one of the things when we have something that is multifactorial, it's nice to have a tool that will take in many of the factors. And so I personally use the ACC-AHA cardiovascular disease risk calculator, which will give you the 10-year CVD risk for our patients. And basically you need their age, their sex, their race, their current blood pressure, their cholesterol measurements, whether they have diabetes, whether they smoke, and whether they're on therapy for hypertension. And you can calculate their 10-year risk. And I'm going to show you an example here of a potential patient. And so here's a 50-year-old male who's white. His blood pressure is 140/85. His total cholesterol is 160, HDL 40. He doesn't have diabetes. He's never smoked, and he's not on hypertension therapy. And his 10-year risk score is only 3.7, so he's a very low risk. Now, if we optimize his risk factors, most notably the hypertension, we could get him down to 1.7 risk. His lifetime risk is still 46%. Now, if we change one item on him, if we make him a smoker, his risk goes from 3.7 to 8.2%, and now he's in the intermediate risk category, and it changes the way we should approach this individual. So, I mean, I like to calculate this for all my patients, and then particularly for my smoking patients, I like to take this in front of them. I actually have this app on my phone, and I'll go over it with them, and I'll show them if we could get you to stop smoking, we could reduce your risk from, in this case, 8.2 to 3.7%. One challenge with this tool, and there are other tools available, and I'm not saying that you should just use this tool, is that none of these tools have been validated with among people living with HIV. So we have to take a grain of salt when we use these tools and recognize there may be limitations. And there have been a number of investigators who have actually looked at that and the use of these cardiovascular disease risk prediction tools and how well they work. And so data from the HIV outpatient study looked at 4 different tools, and you can see them listed here in the top, and I won't read through what they include, but you can see the items that they include, including the Framingham, the pooled cohort equation, the DAD equation, and the score equation, and all 4 underestimated. In other words, the observed events were higher than the expected events. So they failed to fully characterize the performance in people living with HIV. A second study done by Virginia Triant using the data from the Boston group again, she looked at the Framingham risk score and then the ACC-AHA risk equation that I just gave you. And once again, these underperformed. And you can see over here, these dark bars are the observed, and the light gray are the expected. And you can see for every level of risk from 1 up to 10 and higher, you can see the observed were higher than the expected, really suggesting that these equations fail to accurately prevent CVD risk, and they're particularly bad if a person with HIV's risk is greater than 5%. Now, earlier I mentioned that we need to be thinking about traditional risk factors, and NA Accord has once again looked, and what they have identified is, yes, there are traditional risk factors that we need to consider: age, male sex, hypertension, diabetes, low HDL, CKD, whether or not someone uses a statin. But they also found a number of HIV-specific factors that may increase someone's risk. And you see detectable viremia and lower CD4 count as being two key factors. Someone asked real quickly, and I think this is a good question, 8.2% doesn't seem like a bad score to someone. You know, I have some patients that go to the casino, and they do tell me, they say, oh, a 1 in 10 chance doesn't seem so bad to me, doc. You know, I think that we need to contextualize these things, and I do think that it can be challenging for someone to kind of understand what is a 10-year risk, and I think sometimes that can be helpful to have that lifetime risk as well, to see how high that lifetime risk is. I mean, I think a 50% lifetime risk seems much more ominous than an 8% 10-year risk. So I do think that is a challenge to have. Someone else asked about, it's important to remember that most of these risk predictions don't include a family history, and that's absolutely true, and that's because many of the studies from which these are based didn't collect data on family history, and obviously your genes are going to play a big role. So one of the things that we need to be aggressive on, I think, is identifying people who might benefit from lipid-lowering therapy, and here are the recommendations from the ACC about lipid-lowering therapy. And first off, we should at least be checking lipids, and the HIV guidelines recommend annual, at least every 5 years. We also need to recognize that lifestyle therapy is the recommended first step. And then if we are going to put someone on lipid-lowering therapy, the reason that we're doing it is for cardiovascular disease risk reduction. And that's really the most important thing. And so if we put someone on, we want to be aggressive and put them on a moderate to high intensity statin so we can get the most benefit in terms of cardiovascular disease risk reduction. It's important that we have a patient-provider discussion about drug treatment, because there's lots of data, and I didn't put this information on this talk, but people tend to discontinue their statins at a higher rate than we would expect, especially among our population. We would expect, though, they get on their antiretroviral therapy and they stay. And there's a high proportion of people that discontinue lipid-lowering therapy. They don't see it as so important. And so I think that's important. And then leveraging repeat assessments to help monitor adherence and also to have an ongoing discussion with your patients. There are some HIV-specific lipid issues that I think many people are familiar with. Even after we initiate ART, it's not uncommon to see an increase in many of the parameters, and some people have characterized this as been a return to health, and I'm not always sure that that's an accurate statement. And in fact, many people will still have an LDL cholesterol that is well below 160, which is the old NLA threshold for treatment. But the problem is the LDL in many of our HIV patients is not normal LDL. It's often small and dense and more likely to get oxidized and to get deposited into the intima. The HDL may increase, but it may often be below normal levels, and it may be not completely functional in the setting of HIV. Now, there are challenges, and I think for many of us, drug-drug interactions or the inducement of insulin resistance and development of diabetes, side effects and pill burden are things we're all familiar with among our patients, and these are some of the items that we really need to be talking about the challenges. And one thing just to remember, I mentioned this earlier, is even in treated HIV, these oxidized lipid particles are higher and remain elevated, and these are really the drivers of the formation of an atheroma. And there's recognition. We often think about our lipid panel as a snapshot. But however, it's really a lifetime exposure to these bad LDL particles. So I think this is actually adapted from cardiovascular literature. And once again, as we age, if you look here at the black line, all of us are going to age, and as we age, we get more cumulative exposure to LDL. Now, there are certain people that are lacking the LDL receptor. It's a recessive trait, and if you're lacking one of these, you don't take up the LDL as well, and so you can see your exposure is going to be higher because you're not taking it up, and you're going to have more exposure, and you're going to get above the threshold for cardiovascular disease sooner. If you're missing both, you have a lot more exposure, and I think most people have seen people who have had heart attacks in their late 20s or early 30s, and often these people may have a genetic predisposition. Now, women, their threshold may be higher. Men or hypertension or smokers, their threshold before they have an event is lower. And then the goal of lipid-lowering therapy is to reduce the slope of this curve, so we have lower exposure over time, so we don't meet this threshold, wherever the threshold is for us, to have a heart attack. So I think that it's important that we think about, when we do lipid profiles, we're not just thinking, and this may help with that discussion, this is not a one-time picture. This is this is going to be, you're going to have a cumulative exposure to LDL, and specifically oxidized LDL, that's going to increase your risk. One of the challenges I think many providers have faced, until very recently, the guidelines have not even mentioned HIV, but in 2015 this changed, and the NLA had a specific section focused on people living with HIV. And what they state is that we need to be aware that our patients may be at risk, at increased risk, and this is independent of established risk factors. We need to get lipid panels on all of our patients, and we need to be we can count HIV. When we were counting factors by the old NLA approach, HIV could be considered as an additional risk factor. And then statin therapy is first line, and we need to think about drug interactions, and they list 3 agents that are all moderate to high intensity that are preferred agents because of their tolerability and drug-drug interactions. Now, these have been updated very recently, and I'm sorry I didn't add that into the slide, but I think it basically confirms this, that we need to be aggressive at thinking about treating our HIV patients with statins. And there are a number of different statins that you can use listed here. You really, once again, want to focus on using high and moderate intensity statins. I think many of us are moving away from ritonavir and cobicistat containing regimens if we can, to avoid drug interactions, not just for statins but other things, but that gives us flexibility in the agents that we can use, just because there are fewer drug-drug interactions. So I talked a little bit about statins. I just want to show you once again, here's a picture of a CT angiography, and this is from my colleague Janet Lowe and her work. She once again works with Steve Grinspoon up at Harvard, and here you have CT angiography, and you can see here the artery, and you can see right here a plaque at the baseline, and this is one of the placebo patients that they had. one of the things that they saw higher rates of coronary plaque among the people living with HIV compared to HIV negative, but they saw significant regression. This was a placebo participant, and at month 12, you can get a sense in this person, it goes from here to here. You see much greater expansion of the plaque over that 12-month time period. And when they looked over the whole population, what you can see is there was an increase in the plaque volume by an average of about 10% in the placebo group, while there was a 10% decrement with the atorvastatin. So not only, and this is greater than what would be expected with the LDL lowering alone, so suggesting that there was probably some effect, and this is what has been termed the pleiotropic anti-inflammatory effect of statins, that was contributing to reduction of the inflammatory milieu in these plaques. You know, despite this, the effect of LDL lowering is very similar to the general population. In one study by Silverberg et al., they saw a 26% LDL lowering. It seems to have a number of these pleiotropic anti-inflammatory effects. Grace McComsey has led a number of studies looking at rosuvastatin. We've done some work here at our site looking at atorvastatin. Once again, demonstrating that it's beyond the LDL effect, and that may be particularly beneficial for people with chronic inflammatory conditions like HIV. Paul Ridker led the Jupiter study where they looked at HIV-negative individuals with low or normal LDL but elevated inflammation, and they saw reduced events, and this was mediated once again through inflammatory pathways and not necessarily just through LDL. However, when we've looked at different populations, our population here at the UAB Center, or for instance here in this survey through ACTG sites, the use of statins is actually quite low, only 20% in one ACTG. And so this led to support by NHLBI and NIAID to support a large trial called REPRIEVE that is currently ongoing, which is investigating whether statin therapy as primary prevention can be useful in the setting of HIV. So this study is enrolling 7,500 people living with HIV who are on antiretroviral therapy to pitavastatin or placebo, and it's going to follow them for 8 years. And so this is exciting. This study, which I have the good fortune of being a co-investigator on, has just completed or is about to complete enrollment. We closed to screening. It has just over 7,500 people enrolled. The primary endpoint are these cardiovascular events, which obviously are really critical. But what you see is a number of secondary events to those of us who are clinicians is really helpful as well. Inflammatory, immunologic, metabolic biomarkers, and many of these other non-AIDS events that we think may be affected by the similar inflammatory pathways. This is really going to be an unbelievable study that's going to inform cardiovascular disease, and this is the largest study that the ACTG has ever done in people living with HIV. Okay, so things that we can do to prevent cardiovascular disease in our patients. I've hammered home, I think, that staying undetectable is critical, but we need to focus on these other traditional risk factors as well. Smoking cessation, maintaining a normal weight or losing weight if overweight, exercise, healthy diet, cutting down on alcohol and avoiding drugs. We also can think about, another way to think about it are the ABCDEs of cardiovascular disease management: aspirin, blood pressure, cholesterol, diabetes, exercise, smoking. All of these things, similarly, we need to address. Now, aspirin has sort of been up in the air recently with the recent data increasing your risk for bleeding. The U.S. Preventive Services Task Force has really altered their guidance on this. However, for our patients who are between the ages of 50 and 70, we shouldn't avoid using aspirin if they have a 10% or greater cardiovascular disease risk. And once again, we need to be using these tools to identify people who might fall under these categories. Now, with the caveat is we need to be aware of bleeding risk, but nevertheless, these are things we need to do. We've looked at this in our clinic, and we did a cross-sectional study with Greer Burkholder, and what you can see is we only prescribed aspirin 17% of the time for people who should have received an aspirin. There was an increase in aspirin use as you increase cardiovascular disease comorbidities. If you had 1, basically 9%, if you had 4 to 44%, but overall, poor use or inadequate use of this preventive therapy, underutilization. And when we look at other measures, statin use, blood pressure, diabetes management, we tend to not do as well as we should do. So these are areas that really could benefit from more aggressive treatment in our settings. Smoking. It's been a question about smoking, and this is a big challenge in our clinics. While smoking has significantly declined in the U.S. population from 43% to 19% in the most recent data from the census, it's still the leading cause of preventable death in this country. And depending on the survey from people living with HIV, 40 to 60% continue to smoke. And here's some other data from the VA. I'm sorry this doesn't show very well, but current smokers have a 2.73 increased risk of hazard ratio of mortality. And so this is one area that we need to be aggressive on, and we should talk to our patients at every visit if they smoke about considering cessation. Obviously, we all know that this is one of the most challenging habits to break, and we have limited tools, but I think it's incumbent on us to talk to our patients. If we fail to address it in a clinic visit, then we are tacitly approving their smoking. So another thing that I work with Amanda Willig here at my site, who's a PhD nutritionist, and we are very interested in the effects of physical inactivity and obesity. And maybe that's because we're located here in Birmingham, but I think clinics around the country are seeing this. In our clinic, overall, 35% of our clinic are obese. And when you look, physical inactivity, the people with very low activity have a greater risk of being obese. Similarly, for other comorbidities, physical inactivity increases your risk for hypertension, for cardiovascular disease, and for multimorbidity, which we talked about earlier. So we need to talk to our patients about their sedentary lifestyle and obesity. Many of our patients are faced with challenges with diet and food insecurity. So Dr. Willig and I also did a large survey of our clinic population, and despite 38% being obese, we saw some big challenges, failure to meet their nutritional needs. While people were getting adequate caloric intake, the caloric intake they were getting was not healthy caloric intake. Only 42% were receiving adequate protein, only 10% getting adequate dietary fiber, and there was also low micronutrient intake. Strikingly, 55% of our patients were food insecure, so suggesting that they were getting, high-calorie, low-quality food on a sporadic basis. And so something to make sure you're talking to your patients about is lifestyle modification around diet. So cutting even a modest amount of calories, particularly these calorie-dense, sugar and fat-rich foods, can have a big effect. So a Mountain Dew, which is a drink of choice for many of our patients here, a single Mountain Dew is 230 calories. So if someone would just replace the Mountain Dew with water, you can see they could almost cut 500 calories per day and have a big effect on their weight. Here's a study from the general population in what cutting 500 calories a day for 8 weeks did, and you can see a 6.2% weight loss in a very short period of time. So really dramatic. And this also, in this patient population, they showed declines in a number of inflammatory biomarkers that we talked about earlier. So as you can see, it's not just the HIV that may be affecting our patients, but obesity as well. Exercise is a big challenge. Many of our patients may not have a place to go exercise. They may not have ever been trained how to exercise. So once again, having some easy-to-achieve goals to help them have success, and here's some recommendations. The most recent guidelines on exercise suggest that any amount of exercise can count towards your 150 minutes a week. You don't just have to go to 20 minutes at a time. A 10-minute walk around the office can count towards your exercise time. There have been a number of pilot studies looking at exercise and its benefits in people living with HIV. I think we need more data in this area. Here is an 8-week intervention of 3 different modalities: aerobic, resistance, or combined exercise. Marked improvements in muscle strength and cardiopulmonary function among all the groups. But the other thing that was striking was a decline in measures of mitochondrial toxicity and oxidative stress, which I haven't talked about a whole lot, but that's another mechanism through which HIV likely contributes to chronic inflammation and end-organ disease. So a brief summary of the how. So I think we need to keep our eye on the ball, to use a sports analogy, and maintain virologic suppression. But we also need to address the modifiable lifestyle factors and address these regularly with our patients. If we make them important, they may think they're important. If we fail to address them, then we're tacitly approving whatever they do. And then these key traditional risk factors that we talked about, we need to be aggressive in treating these. I think we have sometimes allowed blood pressure to be high or deferred lipids another visit. I think we need to be more aggressive in how we approach these things. There have been some good questions that have come in. So this is one that comes up a lot, and I don't think we know about this completely. So vaping and e-cigarettes, and how do we address this with regard to cardiovascular disease risk? We don't know. So obviously we know that nicotine is a vasoconstrictor, and so that's not necessarily a good thing for people with cardiovascular disease. But we chalked a lot of it up to the carcinogens and other toxins that are in the cigarette. And so there's really not a whole lot of data about e-cigarettes and vaping. In a large cohort that we're a part of right now, we're trying to get a better handle on how people are actually using these smokeless forms of tobacco or nicotine in their lives among people living with HIV, and then we can look to see how that relates to some of their comorbidity. I think that's a big question, not just for our patients, but for the general population. Someone else asked about anemia. How do you address anemia and obesity along with cardiovascular disease? I mean, I think that's a challenging question. Anemia obviously limits someone's ability to be physically active. It's also an independent marker for mortality in many studies. Both anemia and then low albumin are 2 lab markers that we all have access to and we don't always look at, but are really good markers to someone's overall health. I don't know that I have a good answer for anemia. Obviously, we do a workup for anemia to see if there are any reversible causes. And, it's not uncommon for many of our patients to have iron deficiency, and we will replete their iron. When to do blood transfusions is probably a topic for a whole nother time. I think there's a lot of debate about the consequences of excessive blood transfusion. Someone asked about the keto diet has become very vogue, high fat, moderate protein. I think there are data that support the keto diet. I think depending on your patient population, number one, I think putting someone on that, they need to have good counseling and oversight. I'm not sure for our patients who are food insecure, this is the right approach. We need to give them more of a healthy approach that they can easily follow. I find the keto diet very interesting, and I'm not sure that I have answers to how that fits into HIV at all. Ooh, somebody asked the best question all day. What about coffee? Yeah, where's my cup of coffee? How come you guys didn't provide me with one? Jose, I like to read every study that shows the health benefits of coffee, and anyone that is negative or fails to show that, I just don't look at. I do think that there are health benefits from coffee. There are some consequences, but overall, I think it is okay. But I'm biased because I've grown. It's a requirement to survive my day. Okay, so this is a great question that I didn't address, and I don't know. I don't have a good reason why I didn't. What are your thoughts on ART therapy options with regards to cardiovascular disease and HIV? So obviously, there's a lot of literature out there that suggests there are certain antiretroviral agents that may increase your risk of cardiovascular disease. And I think there's growing literature to support that may be the case. However, the effects are relatively modest. And there may be channeling bias with some of those. So I think the benefits of having virologic suppression is the most important thing. That being said, if you have someone who has a high risk, you may want to avoid some of those agents that are going to increase their cardiometabolic risk. So certain agents may increase someone's risk of insulin resistance and diabetes. So those would be drugs that I would avoid. Obviously, we avoid all the older drugs that may cause lipodystrophy, fat wasting, because once again, that probably increases someone's risk for cardiovascular disease. I think we want the regimens that we're currently using that are first-line regimens, all are pretty clean metabolically, and so I think we should be comfortable using those. And I think the primary goal should be to get their virus suppressed. So here's a question. How many patients DC antiretroviral therapy due to myalgias and or new onset diabetes? I think the question was about statin therapy. I think it is not uncommon for, and so I didn't include this because there's not good data in HIV patients, but there's good data in the general population, and actually Greer Burkholder just published some data on this in HIV patients. There's a significant number of people who stop within the first year, and we need to do a better job of reinforcing the benefits. So it's total exposure to bad cholesterol, LDL or oxidized LDL. So we really need to be aggressive in decreasing that with the statin therapy and maintaining adherence. I don't know how we're doing for time, but it seems like we're coming up to an hour and a half, and I don't want to take up too much of people's time. Here's my summary overall. I think we know that HIV and its therapy can contribute to cardiac risk along with traditional factors. We spent some time. It's really critical that we control virus replication. Early antiretroviral therapy may really reduce the risk of this, and so getting people on therapy early, identifying and getting them on early. We don't currently have good either markers or tools to predict risk. The tools that we have available are not bad surrogates, but they're not perfect, as we talked about, and they may underestimate the risk. So you may want to think about that when you're counseling someone whose risk is 8.7 with HIV. That may be higher than that, and you may want to talk about that with them. Clearly, there are some low-hanging fruit for our patients: smoking cessation, diet and exercise interventions. And then statins are really the best lipid-lowering therapy that we have, and have significant benefit in reducing risk. And so we really need to leverage those in people that have higher risk, and then the REPRIEVE trial will address lower risk populations. So a couple other questions have come in. Would you prescribe abacavir for someone who has cardiovascular disease or family history? So I've been avoiding naming any agents specifically, but I think it's a good question, and I think that's the population. If someone had cardiovascular disease, that I would avoid those agents. That being said, I don't know, I mean, family history, I'd want to know that they truly had a first-generation family history who had an early event. If someone, grandfather had a stroke at age 80, that's not going to make me so concerned as someone whose dad had a MI at 35, and I might avoid some of those agents. So another good question is, HDLs seem to be worsening today. I've never seen such low HDLs as over the last 20 years. And I agree, HDLs are commonly low in HIV patients, and particularly in people with more advanced disease. And, we don't have good therapy to improve HDL. Some of the statins will modestly increase HDL. The only therapies that we really have is exercise. And so really encouraging your patients to eat a low-fat diet and exercise, the only choices we have. I'm happy to stay on. You have to answer your last polling question. I have 2 polling questions before you go, and I'm happy to stay on afterwards and answer some questions. So you guys did well in these at the beginning, so you're going to do well again. What best describes the incidence of CVD in people with HIV? Decreasing, increasing, stable. There's no data. I can't believe you guys hung in there with me, by the way. I'm impressed. I talked too long. You guys should have told me to speed it up. All right, so good. I think everybody gets it. Yes, it's increasing. The next question is, which of the following about cardiovascular disease in people with HIV? HIV treatment has no effect on cardiovascular disease. People with HIV experience limited effects on lipid-lowering therapies. The primary rationale for initiating lipid-lowering therapy is to prevent cardiovascular disease. Diabetes does not increase the risk of cardiovascular disease in people with HIV. While we're doing this, people seem to get this one as well. Someone asked about the elevation of triglyceride levels in some of our patients. So if people have a loss of subcutaneous fat, the triglycerides don't have anywhere to go, and that tends to be one of the reasons why we see higher triglycerides among our patients. Insulin resistance can also drive triglycerides high. And often there is some subtle liver dysfunction that may not be manifest in ways that we can tell. So I think that this is a concerning issue, elevated triglycerides. While it may not cause pancreatitis, it suggests there's something wrong otherwise. And usually that means either there's a problem with fat. Either there's not enough subcutaneous fat to store it, or the liver is not doing a good job of processing it. What do we do about it? That's a big challenge, and we're actually working on that right now. Jordan Lake is leading a number of studies to try to address hepatic fat and how to make the liver function better in that setting. That's a really intriguing topic. All right, you guys seem to get that the primary rationale for lipid-lowering therapy is to prevent CVD. We're going through questions now. I'm going to keep moving. I'm watching the questions, so if you have more questions, I'm happy to. This webinar will be available on the website, and there's the link there. I think that not just for this time, there are lots of really great tools on IAS-USA. So if you need CME or you just need some cases sometimes, I think it's really wonderful, and I really recommend them. There are a number of upcoming webinars. I don't know if you guys have not heard Monica Gandhi speak. She is really great, and so I would really recommend Dr. Gandhi.